Welcome to the deep dive. Today, we are taking on what I think is one of the most clinically high stakes and, let's be honest, often visually confusing chapters in medicine, dermatology, and we're using Davidson's medicine as our guide.
And our mission today isn't just to, read the textbook back to you. We're here to build a clinical structure, a kind of blueprint that helps translate those dense descriptions into really immediate, memorable insights.
A rapid access framework, almost.
Exactly. Think of it like that. Because dermatology is so crucial. The skin is, well, it's the body's largest organ, and it can reflect what's going on with your internal health with startling accuracy.
Right, so for everyone listening, the goal here is clarity and efficiency.
Right.
We're going to try and distill the core clinical approach, the essential language you need, and the main principles of management so you walk away with a structure that actually sticks.
And this is so important because a lot of systemic diseases, they have very clear dermatological features. Sometimes a skin sign is the very first clue that something serious is happening inside.
And it goes the other way too, right? I was reading that something like severe psoriasis isn't just a skin problem anymore.
Not at all. We now understand it's a systemic inflammatory condition. It significantly increases your risk of things like cardiovascular disease. The same inflammation damaging the skin is also affecting the blood vessels.
That completely reframes the whole specialty. We're not just looking at the surface, we're actually looking through a mirror into the body's internal workings. Okay, well, let's jump in.
Let's do it.
So we have to start with the absolute foundation, the systematic approach. And we're calling this the golden rule. Because if you mess this sequence up, you are going to miss the diagnosis.
You really will.
The sources are crystal clear. The order has to be history, then general exam, and only then the skin exam.
It is so tempting, isn't it? A patient comes in with this, bright red rash, and your first instinct is just to look at the rash.
Of course.
But that is precisely the mistake to avoid. It's the single biggest trap. Without the history, you just have an observation with absolutely no context.
So you have to understand the story first.
You have to. You need the chronology. You need the triggers before you can even begin to interpret what you're seeing. This is why we have the catchphrase. Don't just look at the rash, interview the rash. You need its whole life story.
I sometimes struggle with what to prioritize in a derm history. So what are the essential components we absolutely have to anchor ourselves to?
The anchors are really all about chronology and exposure. First, you have to nail down the onset and the course of the disease. Was it sudden? Does it come and go? Did it start as just one little spot?
And that helps you separate what, like an acute drug reaction from something chronic like eczema.
Precisely. Then you've got to identify the exacerbating and relieving factors. Does heat make it worse? Does sunlight help or hinder? Does scratching make it spread? All those details are clues.
And then beyond the rash itself, there's the bigger picture, the systemic context.
Absolutely. You need a meticulous past history. And don't just ask any skin problems before. You need to ask specifically about ASAPI.
So that's asthma, hay fever, allergic rhinitis.
Yes, because of that really strong genetic link to eczema. And you must ask about autoimmune diseases. So many connective tissue disorders, like lupus, for example, they present with skin signs first.
And the drug history. I feel like this is the one where it's so easy to miss a key detail. How deep do we really need to go here?
It has to be exhaustive. We're obviously looking for these systemic meds, the prescriptions, but you have to specifically ask about topical preparations.
Things people don't even think of as medicine.
Exactly, and over-the-counter medications. Patients will always forget the topical antifungal they use or a special soap or some herbal cream they bought. And, very often those are the actual culprits causing an allergic contact dermatitis.
I'm picturing a patient coming in with a rash, and they tell you about a new antibiotic, but they forget they also started using a new muscle rub right before the rash appeared.
It happens all the time. And if that muscle rub has, say, a topical NSAID in it, you could be looking at a photopatch dermatitis, which then leads you to the social history. Occupation, recreation, sun exposure, these are mandatory questions.
So what's their job? Are they a builder working with cement? A cleaner using harsh chemicals?
Or do they spend their weekends gardening?
Yeah.
Exposure to plants. And the sun exposure history is critical, not just do you go in the sun. You need to know about chronic cumulative exposure, which is a risk for SCC, versus intermittent intense burning, which is a risk for melanoma.
And finally, to wrap up the history, the human element, the psychological impact.
This cannot be overstated. Chronic skin diseases are so visible, they can be stigmatizing and they can severely impact a person's sleep, their work, their social life. The sources really emphasize gauging this.
So it's not just about how the rash looks, it's about how it makes the patient feel.
Exactly. You might have a patient with psoriasis that looks clinically stable, but if their quality of life score is terrible, your treatment plan has to escalate. You're treating their distress, not just the number of lesions.
Okay, so once that context is fully set by a really good history, we can finally move on to the physical exam, and the instructions here seem very strict.
They're non-negotiable. The patient has to be undressed. Makeup and any dressings have to be removed. And you must have excellent lighting. You can't examine a rash on someone's back through a little gap in a gown under a dim light.
Yeah.
You will fail.
So what are we looking for beyond the obvious rash itself? Where do we find those systemic clues you mentioned?
We call these the neglected sites. You start with general observations, of course, their age, any signs of distress, and crucially, look for evidence of scratching, those excoriations. That tells you a lot about how long it's been going on and how intense the itch is.
But then you do a systematic regional check.
You have to. Give us the tour. Where are the key checkpoints?
Okay, first, the head and eyes. Look beyond the scalp. Do you see any conjunctivitis, any blepharitis? That points strongly towards rosacea. Any eyelash loss? Could be alopecia areata.
Next, the folds. You have to check the axillae, the groins. Conditions like hidradenitis suppurativa or inverse psoriasis, they love these areas.
Third, the mucosa.
You must examine the mouth and the genital surfaces. So many serious conditions show up here. Lichen planus, bullous diseases, drug eruptions, they all can involve the mucosa.
That lichen planus example is a great high-yield anchor. That reticulate lacy white network on the inside of the cheek.
It's a pathognomonic. If you see that, you've got a massive clue for lichen planus.
Yeah.
And then you have to check the genitals, which requires, a careful, sensitive examination.
And fourth, the nails and joints.
Nail involvement is a classic clue for a systemic connection. We look for psoriatic changes like pitting or the nail separating from the bed, what we call onycholysis.
And why is examining the joints so important in a dermatology clinic?
Because of psoriatic arthritis. Somewhere between 5 and 10% of patients with psoriasis will develop this really destructive arthritis. If you don't check the joints, you're failing to screen for potentially disabling systemic disease.
So if you see psoriatic plaques, you have to ask about joint stiffness.
You must. And then finally, the fifth point is the scalp. Look for scarring versus non-scarring hair loss. Look at the quality of the scalp itself. Is it heavily scaled like in psoriasis or just oily like in seborrheic dermatitis?
This whole protocol, it really prevents what you might call rash tunnel vision. You're scanning for systemic red flags the whole time.
That's the goal. If you anchor those features, the mucosa, the joints, the nails, you establish a powerful link between the skin and the internal systems, and that guides your next steps.
Okay, let's do a quick critical thinking check-in based on location because that's a huge part of the examination.
Good idea.
All right, here's a critical check-in question for you. We just emphasized looking at flexor versus extensor surfaces. Now imagine a 19-year-old comes to you with severely itchy, weepy, chronic eruptions, but they're located only in the axillae, the groin folds, and behind the ears. Why must you consider hidradenitis suppurativa or inverse psoriasis before you just jump to a diagnosis of classic flexural eczema?
That's a great question. It moves beyond just simple recall.
So think about it. The answer is that while eczema loves the flexor surfaces, yes, those specific deep intertriginous sites, the armpits, the groin, are also the classic sites for inverse psoriasis, which often lacks scale because it's moist there.
And crucially, for hidradenitis suppurativa, which involves tender nodules and abscesses in the hair follicles. So the patient's age and the quality of the inflammation. If you see deep, painful nodules, that immediately challenges a simple eczema diagnosis. If you miss the importance of that, please rewind and review that list of key observation points.
All right. Now that we have the systematic approach down, we can move to the vocabulary.
Yes, the morphology. This is the alphabet of dermatology. If you can't describe the lesion accurately with the correct terms, you just can't communicate your differential diagnosis effectively to anyone else.
Let's try and nail down these primary definitions. The anchor here is simple. Size matters. That 1 centimeter cutoff is your mental measuring tape.
It's the key. So let's start with the flat lesions. You have maculae versus patches. They're both flat, non-palpable areas of color change. If the lesion is less than or equal to 1 centimeter, it's a maculae, like a freckle.
And if it's bigger than 1 centimeter?
It's a patch, like in vitiligo or a large cafe au lait spot. Simple as that.
Okay, next up, the solid raised lesions. This is where it gets a bit more complex, I think, because now we have to think about depth.
Correct. So a papule is a discrete, palpable elevation that's less than or equal to 1 centimeter. Think of a common wart. A plaque is a flat-topped elevation, almost always greater than 1 centimeter. It's often formed by lots of papules joining together, and it's classic for psoriasis.
And then the nodule. What's the key distinction there?
Depth. A nodule is larger than 1 centimeter, and it extends deeper down into the dermis or even the subcutaneous layer. So clinically, a papule might be a wart, but a nodule is more likely a deeper process, like erythema nodosum or a deep cyst.
Got it. So if I see a large raised lesion, but it feels superficial and flat-topped, it's a plaque. If it feels deep and sort of spherical, it's a nodule.
You've got it. That's the difference between, say, a patch of psoriasis and a lipoma. Now, for the fluid-filled lesions, a vesicle is a small, fluid-filled blister, less than or equal to 1 centimeter. Classic for early herpes simplex.
And a bulla is just a big version of that.
A big version, greater than 1 centimeter. That's what you see in pemphigoid. And a pustule is just a visible accumulation of pus. And remember, it's not always infected. You can have sterile pustules, for example, in pustular psoriasis.
And finally, the ones that involve blood. Purpura versus petechiae.
Petechiae are those tiny, pinpoint macules of blood leakage. Purpura are larger, but the critical clinical distinction is this. You have to check if the purpura is palpable.
Why is that so important?
Because palpable purpura is an immediate red flag. It signals inflammation of the vessel wall, a vasculitis, which demands an immediate systemic investigation. Non-palpable petechiae might suggest a platelet problem, but palpable purpura means the vessel itself is inflamed. That's a huge diagnostic point.
Okay, so once you've identified the type of lesion, you have to describe the whole picture, right? How they're arranged and where they are on the body.
Exactly. The arrangement and the distribution. So first, is it monomorphic, meaning all the lesions look the same, or is it polymorphic, where you see lesions in different stages, papules, vesicles, crusts, which suggests an evolving process like chickenpox?
And for arrangement, what are the key terms?
The terms are vital. Discrete means separate lesions. Grouped means clustered, like shingles. Confluent means they're merging together. Reticulate is that lace-like pattern we talked about. And linear means it's arranged in a line, which often suggests an external cause, like brushing against a plant.
And the distribution gives us huge clues about the cause. We already touched on symmetry.
Yes, symmetrical involvement, so on both sides of the body, usually suggests an endogenous systemic disease, like psoriasis or a drug eruption. Asymmetrical involvement should immediately make you think of an external factor, a contact dermatitis, an infection.
And you mentioned the idea of sparing, where some areas are protected. The example of polymorphic light eruption was really interesting.
In PLE, the patient gets an itchy rash on skin that's been exposed to the sun, but you often see the face and the backs of the hands are spared, even though they get sun all the time. This is a phenomenon called hardening. Those areas have developed a tolerance.
And that's different from other sun-related rashes.
Completely different. Contrast that with, say, chronic actinic dermatitis, where the dermatitis is only on exposed skin, with a sharp cutoff right at the sleeve line or under the chin where a shadow falls. These patterns of sparing tell you a huge amount about the disease mechanism.
This shifts us from the purely descriptive to the quantifiable. Let's talk about the Psoriasis Area and Severity Index, or PSI. This seems critical for justifying some of the more aggressive systemic therapies.
PSI can look really intimidatingly complex, but let's just anchor it around its clinical use. It's a measurement tool. It's used to scientifically track how well a treatment is working, both in clinical trials and in practice. The goal is to objectify inflammation.
So what exactly is it measuring?
Think of it as a four-part calculator. The body is separated into four regions: head and neck, upper limbs, the trunk, and the lower limbs.
And for each of those four parts, we're measuring two things: the severity of the inflammation and how much of the area is involved.
Correct. The severity of inflammation is scored for three key features of psoriasis: redness, which is erythema, thickness or induration, and scaling, desquamation. Each of those is scored from 0 for none to 4 for very severe.
So if a patient has really thick, red, scaly plaques on their back, that trunk section could score a 4 plus 4 plus 4 for a total of 12 on severity.
Exactly. But that 12 has to be weighted by how much of the trunk is actually covered. And that's the second component. The area of involvement, which is scored from 0 up to 6 for 90 to 100% coverage.
And then there's a complex calculation at the end, multiplying severity by area and then by a weighting for each body part. The final score is out of 72.
But the clinical takeaway is more important than memorizing the math. A PSI score above 10 usually means severe disease that needs systemic therapy. But even more importantly, we use PSI to define success. The benchmark in psoriasis trials is achieving PSI 75.
Meaning the patient's initial score has dropped by 75%?
Exactly. That is the objective evidence we need to say a biologic or another systemic agent is actually working. So understanding the R, T, and S scores tells you why a patient is being escalated to a systemic treatment and how you can monitor their progress.
All right, so we've established the history, the exam, and how to quantify severity. Now we bring in the tools to confirm our suspicions.
These are simple, non-invasive tools that can really augment your basic physical exam.
Starting with the magnifying lens, why is this so vital? It's more than just making small things bigger, isn't it?
Oh, absolutely. It lets you see the micromorphology, tiny details that are critical for diagnosis. For example, you can see the pinpoint keratin plugs in a benign seborrheic keratosis, which helps you distinguish it from something more sinister.
And you can see the features of a skin cancer better.
Yes. Under magnification, you can clearly see that characteristic translucent pearled edge of a basal cell carcinoma or the fine little blood vessels on its surface.
And then we can escalate to dermatoscopy. This is essential for looking at pigmented lesions, moles.
It is invaluable. It's mandatory now, really, for anyone examining moles. It uses polarized light and magnification to let you see structures in the epidermis and the superficial dermis that are just invisible to the naked eye.
So you're looking for signs of melanoma.
You're looking for disorganization of the pigment network or atypical blood vessels, which are hallmarks of melanoma. But it also helps you confirm a lesion is benign. You can see specific features of a benign angioma or a Spitz nevus, and you can reassure the patient.
The ultimate tool for telling the difference between just a mole and melanoma.
Exactly. And then there's diascopy. You mentioned this before, pressing a glass slide onto the lesion. But let's talk about why we do this.
So you're essentially squeezing the blood out of the vessels in the lesion. If it blanches, the redness is from blood inside the vessel. If it doesn't blanch, it's extravasated blood, like in purpura.
That's the core principle. But it has a very specific high-yield use. In certain granulomatous diseases, like lupus vulgaris, that's cutaneous tuberculosis, pressing the slide reveals a specific color change. You see these characteristic apple jelly nodules, sort of brownish yellow color that confirms the granulomatous infiltrate. It's a simple bedside test with a profound result.
And when those bedside tools aren't enough, we move to the gold standard, the skin biopsy.
The biopsy is pivotal. It gives us tissue for standard histopathology so we can look at the cells under a microscope to diagnose tumors or inflammatory conditions, but we also use it for very specific tests.
Like immunofluorescence.
Yes, which is mandatory for diagnosing the bullous, the blistering disorders. We look for specific patterns of antibody deposition. And of course, we can use the tissue for special stains for fungi or cultures for bacteria or viruses.
Let's talk about allergy testing, which is central for dermatitis. Patch testing is the investigation of choice for what specific type of reaction?
It's for delayed, cell-mediated type 4 hypersensitivity reactions. So these are the reactions that take days to develop, not the immediate ones like hives. We apply panels of standardized allergens to the patient's back under little patches for 48 hours.
And the most important reading is done when?
Usually in 96 hours. But we often ask them to come back at 7 days because some reactions can be notoriously slow to appear.
But the critical step, as you've said before, is figuring out if a positive test is clinically relevant.
It's forensic work. You might find a patient is positive to colophony, which is a resin in adhesives and varnishes. If that patient works in construction or uses certain nail polishes, that reaction is highly relevant to their chronic hand or eyelid eczema.
But if they have no exposure to it, it might just be an old sensitivity.
Exactly. If it's a preservative that hasn't been in any of their products for years, it's probably irrelevant to their current flare-up. Without establishing that clinical relevance, just telling them to avoid something is useless.
And when do we bring light into the equation?
That's photopatch testing. If we suspect the reaction needs light to be activated, so for instance, reactions to certain sunscreens or topical NSAIDs, we do a photopatch test. We apply the allergen, and then one side is exposed to UVA light while the other is covered. A reaction only on the light-exposed side confirms it.
And finally, photo testing. That's different again, right?
Yes. Phototesting uses a special light source, a monochromator, to expose small areas of the back to increasing doses of very specific wavelengths of light. The goal is to find the minimal erythema dose, or MED.
The smallest dose of light that causes redness.
Exactly. And a patient who needs a significantly lower dose than normal to go red has abnormal photosensitivity. This confirms a diagnosis like polymorphic light eruption.
So this whole toolkit moves the diagnosis from, well, it looks like dermatitis, to it is dermatitis caused by a type 4 reaction to colophony that's active in their environment. That specificity is incredible.
It is. It's the difference between guessing and knowing. Let's test that systemic link again.
Okay.
Here's a critical checking question for you. A patient presents with a large, rapidly expanding, painful ulcer on their leg. You suspect pyoderma gangrenosum. Histology is performed. Which specific finding might rule out a simple infection, and what non-dermatological organ systems should you immediately screen for?
Okay, think about what the term neutrophilic dermatosis implies.
The answer is that while the histology is often non-specific, it will show a dense, sterile neutrophilic infiltrate. But importantly, a specific gram stain or tissue culture should be negative for any infectious organisms, ruling out a simple bacterial ulcer.
And because PG is an expression of systemic inflammation, you have to screen for other diseases.
Immediately, you must screen for inflammatory bowel disease, especially ulcerative colitis and Crohn's inflammatory arthritis, blood dyscrasias, and HIV. If you forgot those crucial systemic associations, please rewind and review the interconnected nature of skin disease.
All right, moving into management. The first steps are always non-pharmacological, right? Confirm the diagnosis, remove triggers, address the psychological impact. But treatment usually starts with the topicals.
And with topicals, you have to realize that success often depends on choosing the right vehicle, the base that carries the active ingredient. It dictates everything: penetration, comfort, and whether the patient will actually use it.
Let's go back to our anchor here. Grease for dry, cream for comfort, starting with the grease side of things.
Ointments. They are greasy, water-insoluble, and highly occlusive. They're the most hydrating vehicle because they stop water loss from the skin. They are absolutely the preferred choice for chronic, very dry, thickened skin like you see in chronic plaque psoriasis.
And they have a lower allergy risk.
A much lower risk. Because they don't contain water, they need fewer preservatives, which dramatically reduces the risk of contact sensitization. The main drawback is that patients don't like the greasiness. They're messy, especially in hair.
Now contrast that with the comfort side, creams.
Creams are emulsions of oil and water. They're lightweight, they absorb quickly, they feel cooling, so they're excellent for acute, weepy, or inflamed skin. Patients vastly prefer them, so adherence is much better.
But they have a higher risk of sensitization.
Higher theoretical risk, yes, because of the preservatives and emulsifiers they need to contain.
And for really large areas, or the scalp.
Gels and lotions are your choice there. They're thin, they spread easily over large surface areas, and they don't mat the hair.
Okay, on to the main workhorse. Topical glucocorticoids. The range of potencies can be pretty daunting.
It goes from mild, like hydrocortisone 0.5%, all the way up to very potent, like clobetasol propionate 0.05%. The choice depends entirely on the body site and the severity of the disease.
So you'd use a mild steroid on the face and genitals, but a potent one on the palms and soles where the skin is thick.
Absolutely, you have to match the potency to the skin thickness.
We have to address the side effects, though, especially with the prevalence of what people call glucocorticoid phobia.
The localized cutaneous effects are what we see most often. Skin atrophy, so thinning and easy bruising, striae or stretch marks in the flexures, and telangiectasia, those little visible blood vessels.
And systemic absorption is a real risk.
It is, with prolonged high-potency use over large areas. It can lead to Cushingoid features and, critically, HPA axis suppression.
Let's just unpack that HPA axis suppression for a second.
HPA is the hypothalamic pituitary adrenal axis. When you apply high-dose steroids to the skin, the body detects it and tells the adrenal glands to stop making their own natural cortisol. If you then suddenly stop the potent topical, the body can't ramp up its own production fast enough, and that can potentially lead to an adrenal crisis.
But despite those risks, the literature suggests that undertreatment is actually more common than overtreatment.
It is. This fear often prevents effective disease control, especially in kids with eczema. It leads to prolonged suffering. The goal is simple. Use the lowest potency for the shortest time needed to get control, then maintain that control with emollients and milder agents.
And quickly, the specialized topicals, calcineurin inhibitors.
Things like tacrolimus. These are invaluable because they provide powerful local immunosuppression without causing the atrophy you get with steroids. This makes them ideal for delicate sites like the face and atopic eczema.
Okay, so when topicals fail or the disease is just too widespread, we move to systemic management, often starting with light therapy.
Right, phototherapy. We harness the power of UV light to induce immunosuppression in the skin. The most common type is narrowband UVB. It's highly effective. It has an anti-proliferative effect on the skin cells and suppresses inflammatory immune cells. It's a mainstay for widespread psoriasis, eczema, and really intractable itch.
And then there's the high-risk therapy, PUVA.
PUVA involves giving the patient a photosensitizing agent, a psoralen, and then exposing them to UVA light. The psoralen gets into the DNA, and when the UVA light hits it, it causes cross-linking, which kills off the rapidly dividing cells you find in psoriasis.
This brings us to that critical anchor. UV light is a double-edged sword.
Exactly. It's an effective treatment, but the mechanism is DNA damage. So cumulative exposure, especially with PUVA, significantly increases the long-term risk of squamous cell carcinoma. This demands really careful lifetime monitoring.
Turning to the systemic agents, the classical immunosuppressants.
Methotrexate is frequently used for severe psoriasis and psoriatic arthritis. It requires careful monitoring of liver and lung function. Cyclosporin is another one. It offers really rapid, potent clearance for severe flares, but it's risky for the kidneys, so it's usually just for short-term use.
And the oral retinoids are key too, especially for severe acne.
Yes, isotretinoin. It's transformative for severe nodular cystic acne. It works by dramatically shrinking the sebaceous glands. But, and we have to stress this, it is highly teratogenic. It causes severe birth defects, so female patients must be on a strict pregnancy prevention program.
Finally, the revolution in therapy, biologics.
These are monoclonal antibodies that target specific inflammatory molecules, offering really precise pathway modulation. For psoriasis, we target the IL-23, IL-17 axis. For severe atopic dermatitis, the breakthrough agent is dupilumab, which targets the IL-4, IL-13 pathway.
It's a huge shift from broad immunosuppression to this very targeted approach.
It is, and we're now seeing emerging small molecules like JK inhibitors. These block the signaling pathways inside the cell that are used by multiple inflammatory cytokines. It's the cutting edge of therapy for these chronic inflammatory skin diseases.
We're now going to focus on 3 critical clinical areas: skin cancer, medical emergencies like blistering diseases, and the systemic causes of itch.
All right, starting with skin cancer. This is a massive public health issue. And the anchor for risk factors is UV radiation. But you have to remember the pattern difference.
So chronic cumulative exposure is the main driver for squamous cell carcinoma.
And its precursors, yes. Whereas intermittent, intense exposure, sunburns, are more strongly associated with melanoma.
Let's start with the most common one, basal cell carcinoma, or BCC.
BCC accounts for over 70% of non-melanoma skin cancers. The good news is it almost never metastasizes. The bad news is it destroys tissue locally, the rodent ulcer. Clinically, you have to recognize the classic features: a pale or pink, translucent papule, often with a raised pearled edge.
And with dermatoscopy, you can see those little abnormal blood vessels on the surface.
The arborizing vessels, yes. For treatment, a standard excision is often curative, but for BCCs on sensitive sites like the nose or eyelids, Mohs micrographic surgery is the gold standard. It has a 99% cure rate because they check all the malignans microscopically during the surgery.
Then the second most common is squamous cell carcinoma, SCC, and this one can metastasize.
SCC arises from keratinocytes, usually on sun-damaged skin. It presents as a firm, scaly nodule or plaque, and it's often tender or painful. And crucially, we have to identify the precursor lesions, like actinic keratosis or Bowen's disease.
And finally, melanoma, the most lethal of the 3.
Yes. Diagnosis needs to be rapid. The essential clinical anchor here is the ABCDE rule. Asymmetry, border irregular, color irregular, diameter greater than about ½ a centimeter, and evolving or elevation irregular.
And the single most important prognostic factor is the Breslow thickness. Why is that specific measurement so critical?
Because it determines everything about staging and management. It's the maximum depth of the invasion into the dermis, measured in millimeters. Tumors thicker than about 0.8 to 1 millimeter often need a sentinel lymph node biopsy to check for microscopic spread. For advanced disease, the revolution has been targeted therapy and the immune checkpoint inhibitors, which basically unleash the patient's own T cells to attack the cancer.
Okay, let's move to the blistering diseases. These are some of the highest acuity medical emergencies in dermatology. Our anchor for managing these is understanding the epidermal split level, where exactly the skin is separating.
Let's start with the most devastating: toxic epidermal necrolysis, or TEN.
This is a massive drug-induced immunological reaction, right? Anticonvulsants are notorious culprits. What makes the split level here so dangerous?
The split in TEN is deep. The whole epidermis detaches from the dermis. Massive sheets of skin just come away. The patient looks like they have third-degree burns. Clinically, this gives you a positive Nikolsky sign, where the skin just detaches with gentle rubbing.
And the mortality is extremely high.
Extremely high. To triage these patients, we use the Scorton score. It's based on 7 factors: age, heart rate, BSA involvement, and some key labs, to objectively predict the mortality rate, which can easily exceed 30%.
Now contrast that deep split with staphylococcal scalded skin syndrome, SSSS.
SSSS is also toxin-mediated, but it mostly affects young children. And the split here is extremely superficial. It happens right at the top, within the stratum corneum. Because it's so superficial, scarring is rare, and recovery is usually rapid with antibiotics. But it is critical to confirm that level of split to differentiate it from the much deadlier TANN.
And now the chronic autoimmune blistering diseases, pemphigoid versus pemphigus.
Bullous pemphigoid, or BP, is the most common, and it typically affects older patients.
Huh.
The split is subepidermal, so below the basement membrane. This causes large, tense-roofed blisters that are hard to rupture. The antibodies are targeting the proteins that anchor the epidermis to the dermis.
And pemphigus is different.
Very different. It's less common, affects younger patients,
Yeah.
and the split is intraepidermal, so within the layers of the epidermis itself. The antibodies target the glue that holds the skin cells together. So the blisters are flaccid, fragile, and they rupture very easily, leading to widespread, painful erosions. This demands high-dose systemic steroids and aggressive immunosuppression immediately.
Finally, let's tackle generalized itch, or pruritus. This is one of the biggest diagnostic challenges. Why is it so maddening for patients?
Itch is transmitted by specific unmyelinated C fibers, and the reason scratching helps is described by the Wall's gate mechanism. Scratching causes a local pain signal, and that pain signal actually inhibits the itch signal as it travels up the spinal cord. It provides temporary relief, but it damages the skin.
So the crucial first step is to figure out if the itch is primary or secondary.
Exactly. If the patient has a primary skin lesion, like hives, then the cause of the itch is obvious. But if they just have generalized itching with only secondary changes from scratching, we have to immediately suspect an underlying systemic disease. The anchor here is, don't just treat the scratch, check the organ systems.
This is a diagnostic mandate. So what are the key systemic causes we screen for?
First, liver disease. Chronic cholestasis, or impaired bile flow, is strongly associated with severe pruritus. It's probably related to endogenous opioids that accumulate when the liver isn't working properly.
Second, chronic kidney disease.
Uremic pruritus is very common and can be debilitating. The accumulation of uremic toxins causes intractable itching. And importantly, the severity of the itch doesn't always correlate with the creatinine level.
Third, and this is a scary one, malignancy.
Yes, generalized pruritus can be the first sign of an internal cancer, most classically lymphoma, especially Hodgkin's lymphoma. The itch can precede the cancer diagnosis by months or even years.
And fourth, endocrine and pregnancy-related causes.
We have to rule out thyroid dysfunction, iron deficiency anemia, and critically specific dermatoses of pregnancy, like cholestasis of pregnancy, which can carry a risk to the fetus.
So management is all about treating the underlying cause, but what can we do for relief in the meantime?
We focus on breaking that itch-scratch cycle. Heavy emollients, counter-irritants like topical menthol, and often sedating each one antihistamines at night, not for their antihistamine effect, but for their sedative properties to help the patient sleep. And narrowband UVB phototherapy can be very effective for generalized itch.
Okay, finally, let's focus on 3 major chronic inflammatory conditions that really anchor clinical practice.
Starting with psoriasis, it's fundamentally a chronic T-cell-driven inflammatory disease, characterized by hyperproliferation of skin cells. The genetics are highly influential. The HLA-C region is key, driving those IL-17 and IL-23 inflammatory pathways.
And what are the key environmental triggers that can cause a flare?
Trauma is a big one. The Kubner phenomenon, where new lesions appear at sites of injury. Infections, especially strep throat, can trigger a specific type called guttate psoriasis in children. And certain drugs, beta blockers, lithium, and ironically, some TNF-alpha inhibitors.
Let's just nail down that cellular pathogenesis again. The keratinocyte transit time is a great teaching point.
The anchor here is speed. In normal skin, it takes a skin cell about 28 days to travel from the bottom layer to the top. In psoriasis, that process is accelerated to about 5 days. This means immature nucleated cells reach the surface, and that's what manifests as the classic silvery scale.
We mostly see plaque psoriasis on the elbows and knees, but we have to be able to recognize the unstable emergency forms.
Absolutely. Generalized pustular psoriasis involves widespread sterile pustules and fever and is a medical emergency. And erythrodermic psoriasis, where over 90% of the body is red and scaling, risks high-output cardiac failure and dangerous fluid and temperature imbalance.
Next, eczema. Specifically, atopic eczema. The core pathogenesis anchor here is the barrier defect.
And the most high-yield genetic link is a mutation in the filigrin gene. Filigrin is a protein that's essential for forming a strong outer skin barrier. When it's mutated, the barrier becomes leaky, it leads to water loss, so you get dryness, and allows irritants and allergens to get in easily, triggering that characteristic Th2-driven inflammation.
And clinically, we see intense itch, the classic flexural site involvement, and a much higher susceptibility to skin infections.
And the highest stakes infection to recognize is eczema herpeticum. This is a widespread, severe infection by the herpes simplex virus on a background of eczema. It presents with clusters of painful, punched-out erosions and requires immediate systemic antiviral therapy.
Given that barrier defect, management has to emphasize repair.
It means relentless use of emollients to create an artificial barrier alongside targeted topical steroids to manage the inflammation. And again, we have to be aware of glucocorticoid phobia because undertreatment leads to flares that can severely impact a child's sleep and schooling.
Finally, two very common facial inflammatory conditions, acne vulgaris.
Acne is inflammation of the pilosebaceous units. The pathogenesis is a cascade of four things: increased sebum, colonization by P. acnes bacteria, inflammation, and occlusion of the duct, which leads to comedones, blackheads, and whiteheads.
And management is staged by severity.
Mild disease gets topicals like benzoyl peroxide. Moderate inflammatory acne needs systemic antibiotics like tetracyclines for 3 to 6 months. And for severe nodular cystic acne, isotretinoin is necessary. It's highly effective, but again, demands strict pregnancy prevention and rigorous monitoring.
Now, rosacea. This is so often mistaken for acne.
It is, but the treatments are different. Rosacea is a chronic inflammatory condition of the central face. You see flushing, persistent redness, papules, and pustules. But the key differentiator from acne is the complete absence of comedones.
So if there are no blackheads or whiteheads, it's probably not acne.
It's a very strong clue. Rosacea also often involves the eyes, so you have to screen for ocular rosacea like blepharitis or conjunctivitis. Treatment often involves systemic tetracyclines for their anti-inflammatory effects, not their antibiotic effects.
This has been an incredibly intensive analysis of the dermatology chapter. We covered that critical sequence of diagnosis history before exam. We mastered the alphabet of morphology, relying on that 1 centimeter rule. We learned to quantify disease severity with the complex but crucial PSI score.
And we established those clinical frameworks for high-stakes scenarios. The epidermal split level for blistering diseases, which separates SSSS from deadly 10, and the mandate to check the organ systems when you're investigating generalized itch. And of course, the management principle: grease for dry, cream for comfort.
We really anchored those key systemic connections, didn't we? The link between systemic inflammation in psoriasis and cardiovascular risk, and the importance of filigrin defects in eczema. We really hope this exploration has given you a robust framework for approaching this essential subject.
And if we connect this to the bigger picture, the profound lesson is that the skin truly is the mirror of internal health. Consider that many of these new targeted therapies, the JK inhibitors, the anti-IL-17 biologics, they were first established as safe and effective in skin diseases like psoriasis. And now they're being leveraged as blueprints for treating systemic autoimmune and rheumatological conditions. Mastering dermatology gives you insight into these fundamental pathways.
That's a powerful thought.
So here's a final provocative question for you to mull over. If you encounter a patient with an unexplained fever and a rapidly spreading, painful macular rash, why must you simultaneously assess for their drug exposure and calculate their Scorton score before you confirm any other diagnosis?
The answer lies in recognizing that rash as a potential sign of Stevens-Johnson syndrome or toxic epidermal necrolysis. Because it progresses so rapidly and has such a high mortality, the clinical imperative is to immediately identify and stop the causal drug and start intensive supportive care. Action has to precede definitive confirmation to save the patient's life.
The urgency of clinical dermatology cannot be overstated. Thank you for joining us for this thorough exploration.